and the and the person using services and how do they relate, how do we relate around that. Let's see, did I miss risks? Yeah.
One of the things that we talked about pretty extensively was that mental health is one of the few areas in which we use a clinical assessment of capacity as opposed to a legal assessment of capacity. And that becomes a real issue, is particularly when we're looking at what level of risk is a system or an individual tolerant of. And I think that's certainly something to explore. Another thing that we talked about here is the idea of who owns risk. And who owns the risk is entirely dependent upon who makes the decision. If a provider is making the decision, they own the risk. If a consumer, an individual, is making the decision entirely on their own about their life, they own the majority of that risk. And risk is mitigated when decisions are actually shared. It's not increasing the risk of liability, it actually is mitigating the risk of liability when you move towards a shared decision-making model. This has been underscored by the state of Washington. Some of you might be familiar with this legislation that has come out of there in the last couple of years, where for health care, they have incentivized the use of shared decision-making throughout the healthcare system by changing the threshold for malpractice. So malpractice risk is decreased if you can demonstrate that you are using a standardized approach to shared decision-making within the clinical encounter. So contrary to some assumptions and initial perceptions, risk is changed positively by use of shared decision-making technology.
By the way, for people that don't know, this knowledgeable person, Lori Curtis, is working with Advocates for Human Potential, lives in Vermont, and is working along with Advocates for Human Potential and Pat Deegan around a SAMHSA project creating tools for shared decision-making. So, I was going to say, we also talked about the risks of not moving forward along this. For example, the effect of not supporting people around employment and moving on, and what that, the kinds of stresses and consequences that providers and peers experience around that. We moved into a pretty rich discussion about what do we do about it, because we were pretty much the society of the convinced, that there are risks, of course, and yes, of course, we want to do something about it, and started thinking about that. And from the very beginning in our dialogue, the topic of dialogue came up very powerfully about we all experience it, the sort of disconnection between people thinking along the same lines, and how do we, amplify that conversation. And we talked about what kinds of factors, given our incredibly busy systems and the people involved, would help incent that kind of conversation. People talked about how successful on some levels the restraint and seclusion elimination project was doing, thanks to Mary Ellen and everyone else, Nikki, everyone else involved in that project in this room. And some of the factors involved was that there were paid coordinators through a SAMHSA grant who are located at the Department of Mental Health, so that there was somebody calling people and setting up meetings and communicating and working on that. There was active enfranchise, paid involvement of peers so that people with lived experience could be at the table. There was a focus on thoughtful process around reporting and dialoguing around outcomes. That once outcomes in restraint seclusion elimination became apparent, there's more motivation. Wow, this really does work. This can happen. And so that was a factor. And then also the theme of how the dialogue between providers and people with lived experience can get painful, where people who have had negative experiences that are sharing them and kind of venting about that, and providers who are feeling like, gee, I didn't do that to you. And how do we move beyond that painful dialogue to practical action to take progress? And in that project, there was support for that dialogue to help us move through that to the human situation. Related to that, also, I know, Ken was bringing up just how the shared decision, getting down to that person-to-person relation is so important, and the idea of being able to talk about sort of examples of experiences between folks, to have that as a focus, really a practical situational discussions, and also the importance of our funding sources, MDHP, DMH, to set standards and expectations. You know, the comment that, you know, forever, you know, we've been talking about implementing certain elements, including peer specialists and other kinds of elements into our system, but it was really our funders saying that here is a, you know, an outcome that we want, here's a process that we want to see. What else did I miss?
I think the other big thing that we talked about was the importance, and I think other groups have already addressed it, of clinical skill. And really understanding not just don't do this, but what else do you do instead, and to a large degree focusing on how you use time differently. It's not an add-on, it's not something else you do, it's how you do what you do differently. So how you do assessment, how you do conversation, how you do service planning, all of those things are done a little bit differently, and the focus has got to be on how we use our time, not what do we add to the time.